I'm taking testosterone, but I'm getting man boobs.
Yeah.
So you could see here that not paying attention to the hormonal network means that you're setting yourself up to failure. You're shifting the entire range. So it's an entire network that you're actually pushing. So it actually takes a while.
There's definitely a place for hormone balancing, especially as we get older, andropause, menopause, but the TRT craze is misguided because if you're just supplementing one hormone, you are going to see downstream effects negatively on multiple other hormones as well. So. Hello everybody, this is Dr. Scott Sherr. I am the Chief Operating Officer of Troscriptions and Health Optimization Medicine and Practice. I'm also a board-certified internal medicine physician specializing in hyperbaric oxygen therapy.
I'm Dr. Ted Achacoso. I'm the founder of Troscriptions and of Health Optimization Medicine and Practice Association. I'm a physician. My undergraduate is in biology, and I'm also trained in pharmacology, medical informatics, interventional neuroradiology, artificial intelligence, socially responsible finance, and other things that are worthwhile understanding.
He could go on for a long time, ladies and gentlemen, but I think he's bored of telling everybody exactly what he does every single time. So today, Ted, I'd like to talk about testosterone. And before we started recording, you were talking about a patient that came into your office that was asking for testosterone. And what did you tell him to do?
Go to a urologist, to give me a prescription for testosterone.
Yeah.
And the reason for that is that I don't do the testosterone replacement therapy, right? I do hormone balancing. So testosterone has been taken out of context in terms of the way it's being treated. It's like it's very American now.
Yes.
TRT. Yes. Yeah. Silver bullet type of thing. Yeah. But you could see cholesterol. I always remind even other physicians of the steroidogenesis pathway, right, which starts from cholesterol and then pregnenolone and leading to cortisol and all of these other things that can be measured right now very quickly, all of those levels. So if you take a look at all those pathways, they're in a network. If you raise testosterone, you're probably going to raise fucking estradiol as well, right?
The conversion, right?
And raise dihydrotestosterone,
DHT,
and I have had patients who are actually women who are actually in jobs that are CEOs. They're running these huge multi-million-dollar companies, and they already have very high testosterone.
Right.
So I don't know whether or not it's a chicken or the egg. Because of their high testosterone, they're actually able to running the company, or it's the other way around.
Right.
And their problems are actually, you see hair loss, right? Because it converts to DHT, the hair starts falling, or they have to get themselves waxed all the time because, cultural demands that you not be hairy and all of those stuff. But then, you could see men with gynecomastia, etc., because of the conversion to estradiol. It's like, I'm taking testosterone, but I'm getting man boobs. So you could see here that not paying attention to the hormonal network where testosterone is ensconced, right? It means that you're setting yourself up to failure.
Right.
And besides, testosterone is an anabolic hormone, right?
Right.
So you should put it in the context of all the other anabolic hormones in the body, like growth hormone is anabolic, insulin is anabolic, etc. And then versus the balance, or after the balance between anabolic and catabolic process, you take a look at the balance, right? What are catabolic? You have your cortisol, you have your thyroid, right? So you have melatonin. So you could see those types of interactions going with them.
Right.
And as a network, they're like gangmates, right? They will help each other. For example, it's very well known that when you give growth hormone, right, you're going to suppress cortisol.
Yes.
Right?
Yeah.
And that's why I'm so fucking annoyed that this is like, why are you being given cortisol? It's like the thing that we're taught in medicine is that you shouldn't be giving it. It's like, holy fuck, this is, adrenals are actually, 7 to 10 grams sitting on top of your kidneys with no parasympathetic innervation, right? And they're the ones producing your fucking cortisol. And you think, what? You're not going to assist the body in this, stress management? So these are the kinds of things that basically gives you a second thought to just giving testosterone alone. Right? They're all linked together.
All linked together. And then we're seeing these TRT clinics that have just popped up everywhere. I guess it's very American, like you said, because you take testosterone, you feel better, you feel stronger, you feel more lively, you feel more manly, right? You feel more like...
And also more is better.
And more is better, that's the American way. But then the challenge is that people are getting on TRT when they're in their 30s now. This is a reflection, though, of a number of different things, right? So if you take a step back and look at testosterone levels, they do start dropping around the age of 30, right?
30, yeah. That's why the youngest patients, male patients, the youngest patients that I usually accept my clinic is 30.
Right.
And that's my basis for that, is that your testosterone declines beginning 30. But that doesn't mean you have to supplement right away.
Exactly,
right?
yeah. So what are the other things that you would do in somebody that came in 30?
I would take a metabolomic test, take a
Yes.
look at their nutritional metabolome, right?
Yes.
Their vitamins, minerals, cofactors, etc.
Right.
You know, there's even products out there with zinc and magnesium and all that kind of stuff. But, you know, really, these are all in the metabolome. And if you correct those, restore them to balance, you'll get a patient or a client who actually will have his testosterone pop right back.
But what about the ice cream, Ted?
Oh, lifestyle advice. Like ice cream is known to depress testosterone. Yes, one scoop will depress your testosterone for 24 hours, right?
Right, yeah.
So that's up to you. If you don't have a date the next day, then fine, right? but remember that it's depression and elevation will also depress and elevate other hormones within your system.
Right. Yeah.
Right?
Yeah.
So, you know, when you're giving, for example, in the classic TRT, you have to give the axis a rest.
Oh,
right?
the rest, yeah,
the
sure.
HPA axis a rest.
Yes, yeah. This is what you do, but this is not what most TRT places do, right?
Yeah, no.
So what you're talking about here is that if you take testosterone, your balls are going to shrink, right?
Yeah.
Because you no longer need to make your own. So the way you describe this is by giving the testosterone a break, right?
Yeah.
And using some of these other stimulating
like
hormones.
a low dose of GnRH, for example.
Right, and that's the hormone that comes from the hypothalamus that stimulates the pituitary to make your LH, right?
Yeah. So, you're touching in there now on LH and FSH, right?
Right.
So, in the testicles, right, the effect of LH is that's the interstitial cells of Leydig, right? So they produce testosterone, and then you also measure FSH, right? FSH would be the follicular stimulating hormone, and that would be for the fertilized cells, and that is for the production of sperm, right? So as we age, you know, both of those functions decline, right? You know, as you get older, you have lesser seminal volume, longer orgasms, but you know, less seminal volume. But if you take a look, we're now going into the phenomenon of andropause, you know, which is one of the things that diagnosis I introduced in Manila when I started practicing there, you know, almost 2 decades ago, is that the FSH and LH is coming in from the brain, right? And it's screaming for the testicles to produce testosterone and sperm, and it won't, right? So it screams louder, right? So when in true andropause, you'll see that the FSH and LH are really, really high, and then the testosterone is low, right? So it's actually very easy to see that, coupled with a history, right? If you take a look at a patient who's 40, right, you know, usually comes to me already with some sort of antidepressant, right? Is already an antidepressant, is irascible. The wife is there complaining about, you know, how angry and irritable he is, and so on and so forth. And if you take a look, this is a classic picture of, you know, a man actually undergoing, you know, an early andropause. Right. And that's about, you know, where you get the midlife crisis. You know, and
the Ferrari.
Actually, it has shown that you know, that being around beautiful women, for example, will raise their testosterone, right? And buying a car that's reminiscent of their Playboy days, for example, is surrounding themselves with the environment where they used to feel. Is it right? Used to feel like they had high testosterone. And then when you institute hormone balancing, focusing on testosterone therapy, what happens there is that you can take, you know, they begin to, after about 3 months, they begin to be back to their old selves. Right? And they actually you can talk to your psychiatrist and say, hey, we can take this off now, right? They're not depressed anymore, and so on. And we're not paying attention to this because in females, menopause is very sudden, right? Of course, there's perimenopausal period now, but for many women, it just occurs suddenly and the menses stop, right? Just very short perimenopausal period, although some take 5 years or more, right? But for men, it's very gradual.
Right.
People do not really notice from HRD. It's very gradual, so that they think it's just like they're just really getting angry and more irascible over time, right? But really, their testosterone, not only testosterone, there are other hormones also.
Growth hormone goes down, for sure.
But the main hormone that's being pinpointed for midlife crisis is actually testosterone.
Yeah.
But people have to understand that it's within a network, right? So if you come to me and asking for TRT, I'll tell you to go to another doctor who will provide the script, right? Because I will have to monitor all your other hormones that are going at the same time, right?
Yeah, and at the same time, also making sure that you're optimizing them from a cellular perspective, as you described, right? So vitamins, minerals, nutrients, gut health, lifestyle, behavior. So if they're not sleeping well, their testosterone's going down. If they're eating too much ice cream, their testosterone's going down. If they're watching porn, which one does it go up or down?
It goes up.
It goes up
temporarily,
and then goes down. Okay, and as if you ejaculate, it also goes down, right? So. So anyway, there's all these lifestyle factors associated with...
and people also have to be aware of what testosterone they're getting if they're getting on testosterone therapy. I don't usually recommend pellets, but there are people who are comfortable with pellets. It's like I tried the 3-month injection, and you take it the first time you take it, you want to fuck everything inside. It's like, and then a steep drop off after that, right? Yeah. And it doesn't really last 3 months, right?
Right.
So for my patients, I actually was one of the pioneers of doing subcutaneous testosterone and injections of testosterone. So I have a cutoff, and this is, it may be different for people in practice, but I noticed that 55 and above, I place them on subcutaneous injections already. Before that time, you could still actually use transdermal types of testosterone. For and for 28-year-olds, etc. They even respond to clomiphene citrate, right? And all of
the drug that helps release more.
So for me, it's just like you look at the bodybuilder lore. I use support a lot into bodybuilding forums, etc., etc. And
you used to work with a lot of those guys.
Yes.
Some of their steroid. We won't talk about that. Never
Well, steroidogenesis pathway, right? There are many equivalents of testosterone that are more powerful than testosterone, but less androgenic than testosterone.
Yes.
Right?
We had a guy on our podcast, the Smarter and Harder podcast, talking about that very much. Patrick Arnold.
It's a very interesting subject matter because very few physicians are really interested in helping these bodybuilders out, right? I think the story that you heard is about this, regional winner and now wants to get married and have kids, and no doctor would touch him because he had no more balls. And I said, our responsibility as physicians, like, hey, if I don't know this and other people are willing to help you, let me study and let's see what we can do for you.
Yeah.
Right?
So how'd you rebuild it?
It took me 2 years to actually do that combination of various, basically restarting your hypothalamic pituitary gonadal axis, right?
Right.
Because he's young. I mean, he was a champion at 18.
Wow.
Right?
Yeah.
So you could see that he came to me at 20, and I had to work until
to reboot his brain. Reboot the hypothalamus.
Reboot the hypothalamus, and also essentially, there's a lot of like lore or misconceptions in that, and the conflicting science and so on. But for me, I tend to keep it simple for them. If we just follow the fundamental cell and where the biochemistry goes, you could generally figure out what you can and cannot give the patient or the client. Essentially measure doses of GnRH towards the later part, but first health optimizing him.
Health
optimizing him, the lifestyle, everything else. Because they suppress cortisol a lot, right? Actually you need that for survival. Cortisol is kept at a very narrow range by the body. It's like it's demonized by bodybuilders. No. I said let's bring that back in. And so on. And of course they're loath to do that, but hey, he wanted to get married and have kids. So,
one of the things we always talk about as well when we're talking about hormone optimization is what ranges we're talking about here, right? Because I think that's another big question. When we get this a lot from patients, we often talk about how if you're measuring somebody's TSH,
Yeah.
it's a TSH that's been an average of like somebody between 5 years old and 91 years old.
Yeah.
And that's the entire range, not your
Yeah.
normals in there.
Yeah.
What have you developed? And this is something you kind of pioneered, right?
You touched on that, and I was shocked to find out that the thyroid ranges were from age 3 to 94,
Yeah,
right?
something
And it's
crazy.
like, why is my normal supposed to be in that particular average, right? What I looked at in optimization means when in your life cycle are you in optimal health?
Right.
And the thing that I chose in there is your golden years for reproduction is about 21 to 30,
Yes.
right?
Yeah.
So that's that's essentially the age range where we try to bring you back. So in Paris, we bring patients back to 25 years old, plus minus 2 standard deviations. We're more gung-ho there. In the United States, we're more scaredy cats. So we actually push you to, as long as you cross the 30 barrier, that would be fine. However, the range of Terry Hertog is 25 plus minus 2 standard deviations. The range of Mark Gordon, right?
Yeah, Dr. Mark Gordon. Yeah.
Mark Gordon, I think he goes
little bit
by
younger, I think.
he goes by the median values.
That's right,
median
median values, yeah.
Right, and then I go by your percentile. Between 50th and 75th percentile for between 21 and 30,
right,
which is a little bit more acceptable as a range, right? Because the others have extremely high testosterone, others have low, but then if you go 50 to 75%, you're good to go in that.
Yeah.
But putting patients back in that range, doesn't necessarily mean that it's only testosterone going to put it back.
Yes.
Right.
Yes.
So
Yeah.
even for your metabolites, right, you bring them back to that level of between 21 and 30, and that's what most people don't understand about the practice, is that you're shifting the entire range. So it's an entire network that you're actually pushing. So it actually takes a while.
Takes time, yeah. I think that's the key, right? Is you don't want to be normal for 63 years old. You want to be optimized when you were the most optimized in your life cycle, which would be between 21 and 30 years of age.
Yeah, when you had sexual activity several times a day.
Fornication, fighting, surviving, fitness function, right? That's when we're 21 to 30. So yeah, the fitness function is something that's a Donald Hoffman thing, right? So,
the 4 great F's of men. Right?
What are the 4 great F's of men?
Feeding, fighting, fleeing, and fornication.
Ah, yes.
Yeah.
Those are them right there.
Yeah.
So, so I think when it comes to hormone balancing and TRT, there's definitely a place for hormone balancing, especially as we get older, andropause, menopause, but the TRT craze is misguided, because if you're just supplementing one hormone, you are going to see downstream effects negatively on multiple other hormones as well. So.
The key concept here is network, right? Once you touch one node in a network, the rest of the network moves. So you better make sure that the movement of the major nodes in the network are actually also taken care of. Look, Microsoft cannot move, in the AI world, Microsoft cannot move without knowing what AI is doing, without knowing Google is doing, what Apple is doing. So all of those, you're monitoring all at the same time, especially if you're, for example, picking stocks. Why it's the same principle for your hormones. So.
So for those listening, please don't take this as medical advice. Make sure you find a clinician to help you, but just be aware that TRT itself may not be the best way to go for many people, but not all. Talk to your doctor and figure it out.